This is going to be a very brief touch on a number of topics, so I'll be moving very quickly. But as Dion has told you, the slides will be available, so don't worry. You can always come back and ask questions of me via email later because I'll be, as I said, moving very quickly. And these are the areas that I'm going to touch on, which were outlined, and so I'm going to try and do all of them. It's a pretty ambitious task, but let's see how we go. The first issue to start off with, I guess, is what is the addictive potential of cannabis? And, of course, it's still, for some reason, up for discussion despite the very strong body of animal and human evidence. And this work is more than 10 years, even up to 20 years old, the first work that Jim Anthony did on the addiction potential of cannabis. And as you can see there, it sits somewhere between amphetamines and the benzodiazepines. And that means that around 1 in 9 to 11 people who have ever used cannabis go on to develop a dependence. Oops, sorry, I used my mouse instead of the other thing. I just wanted to highlight in this slide, where we think of high-risk groups for a cannabis use disorder, we think of the stereotypical younger person, perhaps in their mid-20s. But I just wanted to highlight from the National Drug Strategy Household Survey that, in fact, it's the 40 to 49-year-old group that has the highest percentage of daily users, and of course they're at the greatest risk of developing dependence at around 17%. So we need to keep our clinical eyes open that it's across the age groups and actually increasing with age, with now our 50 to 59-year-olds being our fastest growing group of users. Now, the most recent Australian data that we have with a specialist collection, and this is from the National Survey of Mental Health and Wellbeing in 2007, where they did a full psychiatric interview with a representative sample of Australians. And they found that the lifetime rate of cannabis use was 18%, and of cannabis use disorder was 6%. Past year cannabis use was 6%, and a current cannabis use disorder was 1% of the population. And of course, that's the whole population, and 60% of them have never used cannabis. So what is of more interest is what we call the conditional rates of cannabis use disorder, and that is the rate amongst those who've ever used. And amongst that group, the rate of lifetime dependence goes up to 32.3%, and amongst users, a current diagnosis goes up to more than 1 in 10, 14.3%. And that data set also told us what were the predictors of cannabis use disorder. As we know from our clinical studies, it's the most common disorder amongst males. They're twice as likely to meet criteria for a diagnosis. And those that start younger, which Wendy touched on, they're at a higher risk of developing dependence as well, at around 4.5 times the rate of older users. We see associations between a current cannabis use disorder and alcohol use disorder, where those who are having problems with alcohol are more than 3.5 times more likely to also have a problem with cannabis, and 3 times as likely to have an affective disorder, a mood disorder. We also know that most people with a problem don't seek treatment, and that was confirmed here with with only a bit over a third of those with a current disorder having sought treatment. We sometimes fall into a therapeutic nihilism, if you like. It's all so hard, they never quit. And I guess that's because we tend to see those that are really finding it tough to quit. So just to put a positive note in here from 2 waves of a big American NCPIC survey, and they found that actually only 6.6% of those with a cannabis use disorder relapsed. And the things that predicted relapse was how long they had been quit, so the less time they'd had clean, if you like, the more likely they were to relapse. And having a history of a conduct disorder or being currently depressed also meant that it was more likely that you had also relapsed back to cannabis use. So the rates aren't as bad as we see in our clinical populations. In the general population, certainly we're seeing quite good success rates. So looking at treatment supply, and this is from the National Minimum Data Set, and there we see that cannabis users are taking up a pretty large proportion of our treatment resources, second only to alcohol. 1 in 5 of treatment episodes in Australia are for cannabis, around 22%, and upwards of 30,000 treatment episodes per year. When you also include other drugs of concern, so someone who's come in with primarily an alcohol problem but is also wanting to address their cannabis problems, it's more than 40% of those in treatment also need some assistance around their cannabis problems. As we see with the criteria for dependence, males are more likely to also be in treatment, but they tend to be younger in treatment, around 25, whereas the average person in alcohol treatment is around 40. As with all other drugs, counselling is the most common intervention that they are provided, although 13.4% of withdrawal episodes are for cannabis withdrawal and around 3% of residential rehabilitation, and those resources are very scarce, so some would think it unusual that any people with cannabis problems only would choose to go to a long-term residential rehab, but this is definitely the case. I just want to touch on tobacco because people ask about this quite often. So just to make the point that the polygenetic factors that influence cannabis use also influence tobacco use. They seem to have factors in common. Cannabis smokers who also smoke tobacco are more severely dependent. They have more psychosocial problems and they have poorer cessation outcomes. Tobacco smokers not also abstaining from tobacco are at the highest rate of relapse. So we know that dual abstinence predicts better outcomes for each. So, slap on the nicotine patch while you're doing your cannabis intervention, because encouraging people to also give up tobacco will help them with both disorders. So very quickly moving on now to looking at cannabis withdrawal and what we might be able to do there to assist people. This is a new and emerging area of interest. Cannabis withdrawal, of course, is now a discrete DSM-4 syndrome, and we are recognizing more and more that it does drive people into relapse where they just cannot manage to get through the withdrawal syndrome, particularly the long tail of sleep problems. We've done some good research here in Australia. David Alsop led this research with us, looking at developing a valid measure, and that was really the basis and the bedrock of where we started with doing further cannabis withdrawal work. And this work is published, and the cannabis withdrawal scale is available on our website, and the papers will outline to you that those are the principal problems: the irritability, anger and aggression, and the sleep problems, of course, are very important. So the proportion of patients reporting cannabis withdrawal in recent treatment studies ranges somewhere from a half to almost everybody. Typically, the majority of symptoms commence on day 1 and peak on days 2 to 3. The later onset symptoms are the aggression, which can move on to kind of a real hostility and anger, and are seen sometimes to peak at 2 weeks post-abstinence. As I mentioned, the strange dreams are typically the most persistent symptoms as slow wave sleep returns. And we've recently, if you have a little look on our website, you'll see that we've recently published some new work on sleep, and it's been published in Sleep Reviews. Withdrawal management is typically in the community with the usual kind of care of education, some CBT and social support. And as with other substances, the clinical indications for perhaps bringing them into an inpatient setting, that they're really struggling, or that their families are struggling with them going through a cannabis withdrawal at home, or that it is exacerbating major psychiatric illnesses. So, moving on now to what we might be able to do to assist people, and certainly there is no evidence-based medication yet that's out there and available. A number have been tried, and you can see here the range of neurotransmitters and modulators and other medications that have been looked at. And I received an early question about Epilim. Epilim and Divalproex are very similar. In fact, they're the same drug family. So the answer to that question is no. Epilim is quite likely to actually exacerbate cannabis withdrawal and is not recommended by any evidence-based research at all. The red box there indicates the agonist medication, the dronabinols and the nabilones, where the work has been done in the US, where they do help some of the withdrawal symptoms, but not the full range. So what we've been doing here in Australia is we've been looking beyond the oral medications. As you can see there, as you move through those oral synthetics that we've mentioned, through nabilone to Sativex, and of course the drug that they're actually interested in, which is smoked THC, you have increasing bioavailability and therefore absorption. So the other desirable drug properties about replacing a full botanical THC-CBD combination is it is quite low intoxication. It has a speedier onset and duration of action than the oral synthetics. Those of you who aren't familiar with the Sativex medication, it's been licensed here in Australia now for treating neuropathic pain in multiple sclerosis, where other medications have failed. It's a mouth spray. It's administered in a metered actuated dose of 100 microliters in each spray, and it's pretty much 50-50 THC CBD. And once again, this study was a collaboration with Adrian Dunlop, Nick Linceris, and the project was coordinated by Dr. David Alsop. And the primary objective was to measure the safety and efficacy of Sativex in an inpatient withdrawal situation, and to compare it to placebo for cannabis withdrawal severity, whether or not they completed detox, and any adverse events, including, of course, whether they became intoxicated. We also looked at 1 month post-withdrawal outcomes, their levels of cannabis use, and any other associated problems. I won't go into all the eligibility criteria. As you can see there, they're pretty standard, that it was principally a cannabis dependence problem, and that they were likely to experience withdrawal and to sign up to all of the criteria for the study. And similarly, the exclusion criteria were to make sure that, in particular, people weren't likely to be pregnant or breastfeeding, and the fairly standard criteria otherwise. Now, the trial design. We recruited 51 treatment-seeking dependent cannabis users who were willing to go into a detox, and we randomized them to receive Sativex or placebo for 6 days, followed by a 3-day period to wash out the drug and get them back to baseline. Treatment took place in 2 public clinics here in New South Wales, and so they also got the standard regime of care that is available in Australian withdrawal units. The peak dose delivered was 80 milligrams of THC and CBD as combined in 8 sprays 4 times a day. So the peak was on days 2 and 3 of their abstinence. They got the biggest dose then before they were tailored down. And this is the highest dose of Sativex that had been given in any clinical trial, including the earlier ones on multiple sclerosis. So we were very keen to to see how people managed with that dosing level. I won't go through this in detail, the demographic and drug use comparisons, but in essence there was no difference between those that received the nabiximols or Sativex and those that received placebo. In general, they were males in their mid-30s. They'd been using cannabis for around 20 years, and they were severely dependent. So what did we find? Our main outcome measure was the cannabis withdrawal scale, which of course is a validated measure. And overall, the cannabis withdrawal scores were significantly suppressed by Sativex, and it was a strongly significant result. The symptoms that contributed to most withdrawal suppression were craving, which of course is a tough one to help people manage, irritability, which is a key one that they and their families complain about, decreased appetite, insomnia, some of the physical symptoms, and depression. So in terms of the effects on retention, we know that retaining people in any kind of substance use treatment is a challenge, but some people feel that cannabis patients have another order of difficulty in retention. And we found that the participants were retained in treatment significantly longer when they were on the Sativex group. And as you can see at the end of the medication where the dotted line is, and thank you David Alsop for this slide, only 50% of the placebo group was still in treatment, which was around 12 of the original 24. But 85% of those on Sativex were retained in treatment, which was 23 of the original 27. And finally, the concerns about abuse potential, about intoxication. People are always concerned about this when you're giving people agonist medications, because we don't want to then create or exacerbate and prolong their THC dependence. However, as you can see from the graph on the left, participants receiving Sativex did not report feeling significantly more intoxicated than those on the placebo. And the second graph there on the right, when we asked people which medication they thought they'd been on, the majority didn't know, 60% didn't know. So the blinding was successful, and interestingly, of those that nominated Sativex, they were not significantly more likely to be on Sativex. So that was very encouraging. So, in summary, once again, thank you, David, for reusing your slide. Sativex significantly suppressed withdrawal-related irritability, anger and aggression, depression, appetite loss, cannabis cravings, and importantly, when we summed the scores of all of the withdrawal symptoms, the total syndrome was suppressed. We were also able to retain them in treatment longer than placebo, and they were not intoxicated, and they couldn't tell the difference between the medications they were receiving. So the take-home message is that there's certainly some good initial support for Sativex in the management of cannabis withdrawal, and we, Nick Linsaris is now leading the group, and an application has gone into the NHMRC for a larger study on that question. So let's hoping that that is successful. But there are some drawbacks with Sativex. In particular, at this point in time, it's not licensed for this purpose, so it'll be a while, even with further studies, for it to be available. It is quite costly. There is a storage problem. It has to be in a locked refrigerator while it's in the pharmacy setting, so that's a bit of a barrier for pharmacists. And also, of course, people cannot drive when they're taking Sativex, because we did the oral fluid testing, the same as roadside drug testing, and it can be detected for 2 hours for people who are driving. So that's a bit of a barrier as well for young people. So the next place that we really wanted to look was cannabidiol, and Wendy has filled you in on that, so I don't need to say any more, which is great. We're at the very early stage of feasibility testing with this medication. We're doing an open label trial, which means the patient knows and we know what they're getting in an inpatient setting for cannabis withdrawal. And then we're going to, same as the Sativex, follow them up at 1 month post-admission and see how they're going. We're going to run between 5 and 8 subjects. We've already run 3 in this particular study at the Nepean Hospital Withdrawal Unit. So if you're in New South Wales and you think you have someone who would really benefit from this medication and is willing to go into hospital, please let me know. It's also a 7-day admission where people get 300 milligrams of synthetic CBD twice a day for 5.5 days and a day and a half of washout. So that's one that is watch this space because it's not available yet. So looking now at the psychosocial interventions, and I realise I'm running out of time, so this is just going to be a dot point mention. Typically, people want the least possible contact with treatment services, and that's been reinforced many times in a range of studies, but to take heart that even psychoeducation alone has a positive effect on use, harms, and treatment seeking. Amongst adolescents, as Wendy mentioned, it's particularly important to delay primarily, but if not delay, then certainly treat as soon as possible an emerging adolescent cannabis use problem. And the adolescent cannabis checkup, 2-session intervention, has very good support in the literature, and we're able here at NCPIC to provide free training on how to deliver this intervention. So if you're interested, please contact us. And at the other end of the scale, intensive multidimensional family therapy that Howard Little's group has done a lot of work on has the strongest evidence base for those young people with really multiple social and other problems that has proven to be a very promising approach. Both US and Australian studies confirm that between 1 and 9 sessions of CBT is the most effective approach, including all of those components you're familiar with: case management, coping with urges, handling triggers, challenging positive expectations, coping skills training, and relapse prevention, wrapped up in a caring motivational interview style. And Eva Hock, who spoke here recently, is doing some great work on Cannabis, which is a slightly longer version on translational work across Europe. So please do have a look for her work if you're interested in a variation of that kind of intervention. And similarly to the adolescent cannabis checkup, our training team can also provide training in this particular intervention. I didn't want to not mention contingency management, but just to touch on it because it's not used here very much, if at all. But we do know that incentive-based vouchers do increase the effectiveness of CBT, and that these incentives can be for attendance or by extension kind of reinforcing good behaviour, as it were, with engaging well in treatment, cannabis-free urines, etc. And a range of studies there, which you can look up if you're interested, are trying to identify what are the core elements. But interestingly, it not only works for adolescents, it also improves the parents' behaviour when you're trying to intervene with a family. Gender issues, taking me back to my origins, there are some gender differences in relapse patterns. Women are more likely during withdrawal to report physical symptoms, so that should be attended to and supported. And women are more likely to report continuing to use to maintain their social network, so being in a relationship, to remain abstinent after treatment, which is great, to relapse in response to negative feelings and interpersonal problems, where we know with men they're more likely to relapse in positive situations where they're feeling very sure of themselves and up. And interestingly, women also experience after withdrawal greater craving in response to cannabis cues. So helping them avoid high-risk situation and cannabis cues might be certainly of interest to pursue. Just touching briefly on options that your clients might be directed towards is our Reduce Your Use website. Oops, it just moved by itself. Anyway, it's there on our website. It's free of charge, 6 sessions. This is the findings of the randomized controlled trial. So it's an evidence-based intervention, so you can feel confident to offer it to your clients while they're either waiting to get in to see you or as an alternative if they're not very engaged at that point. The other, of course, is our free national helpline, and over that national helpline of 1-800-30-40-50, we also did randomized controlled trial to make sure that intervention was an effective one, and that's published in Addiction. Peter Gates led all of that work, and that's there once again to be used in the same way with your clients. And the next generation, of course, is smartphone apps, and this is further development of Sally Rook's work with the web-based intervention. We know that mobile phones are in everybody's pocket pretty much these days, from teens through to the grey nomads. Everybody's got their phone handy, and it really increases the availability of assistance. They're very well suited. As I said, it's convenient, accessible, and private. We've done a range of developmental work. We did a lot of iterative work with a group of cannabis users to get it to a usable stage. We tested it for a month with a small group and found that when it had been turned off for a month, there was reductions in the quantity of cannabis use and distress and dependence, and also an increase in coping. And this study is now in a full randomized controlled trial. So watch this space. I hope we can present some preliminary data at APSAT or other meetings to see how that's panning out. And we're also hoping to further development the work to increase and its reach and include an employment focus. So I can't tell you very much about brief interventions in the next 3 minutes, but do look at our workforce section on our website, and you'll find materials such as this, information on screening and assessment, the things that you might want to cover, the questionnaires that are available on our website. Here are some of the possible questions that might want to use to trigger a conversation around someone's cannabis use when they present. Comments like, what do you think it would take for your symptoms to improve? What would things be like for you in the future if things stayed the same for you? And how would you like it to change? Can sometimes help shift the conversation along. For those that aren't interested, just obviously feeding back that you hear that, and we'll kind of, respect where they're at. But just asking them if they're interested in knowing more about it, if they're willing to take written information and pointing out referral agencies, and keeping the door open, of course, for future engagement. And for those that are receptive, of course, the key message is to allay fears, to clarify the issue for them and with them, give information and feedback, choices about intervention, and information on referral. And I don't have time to go through the key elements of an intervention, but just to refresh your memory, they're essentially the 5 A's, which are, of course, ask, assess, advise, assist, and arrange. And the brief interventions, of course, are typically using the FRAMES kind of acronym, if you like. So for those who aren't aware, and hopefully there aren't any of you out there that aren't, these are the range of resources that are available, and of course we have the free training as well that goes with these. Our website has a wide range of information, and it's going to undergo a big refresh in the next few weeks. And our information and helpline, ring the people there. They're absolutely charming and extremely well informed, and they can provide interventions as well. And if you're not receiving our e-zine, please also sign up for that. And for those of you who work with young people, we have a web-based version as well as a booklet version of Clear Your Vision, which is proving really popular with young people. And if you work with Indigenous peoples, then we also have a range of intervention materials, of ways of engaging around music and in school settings. So please have a look at that area on our workforce section of our website.